everybody. We are officially going to start now that we don't need to talk about bow ties. I'm Michael Munson with Forge, and we are happy that you're all here tonight with us to talk about hormones and how they might play a role for non-binary folks, which is a subject that we don't hear a lot about. So I'm really excited to kind of have this conversation and hear what Annie has to share with us. But let me get started with a couple of housekeeping items, which many of you have heard already, but I will share them again for folks that are new. We are recording tonight so that folks that can't be here can have the opportunity to hear it later. So if that affects how you would like to ask a question later, maybe by chat instead of by voice, please just keep that in mind. And we can always edit out anything if you would like that as well. We do have an ASL interpreter, as you can hopefully see if you're looking at your screen. If you would like to pin either of our ASL interpreters, you can go to their picture and click the three little dots and then click pin, which will allow you to have them be front and center. In a few days, you'll be able to pin more than one person, so you could pin Annie and Jill, for example. So that will be a cool new Zoom enhancement. We also have cart captioning tonight, so if you would like to see captions, you can click on the CC button at the bottom and have the option of showing it at the bottom of your screen or to the right of your screen. So those are some of the logistics of tonight. And I wanted to make sure that we thank our funder, who is the Advancing a Healthier Wisconsin Endowment at the Medical College of Wisconsin. It's allowed us to partner with the Medical College of Wisconsin and the Inclusion Health Clinic. And it's been a really fun ride, given that we're in the middle of COVID and it was funding that was specific to COVID. So I think that we've had some really interesting programming that's evolved out of that. So that's really cool. We want to make sure that folks are familiar with Zoom, so I shared with you about how to pin somebody's image if you'd like to do that. Many of you have already found the chat, but let's practice finding the chat. What about typing in what is a synonym or a word that is similar to you for the word non-binary? So people are saying gender fluid, genderqueer, gender expansive, queer, fluid, gender nonconforming. Swan, yep. Liberated. Excellent, really excellent. So many of those words are what many of us use day to day. There are many more words than that. I think we're going to probably use the word non-binary as kind of a catch-all to mean all of those words and many more. And Annie will tell us if she's going to do something different. But when I tend to use the shorthand of non-binary, it does include all of those identities and many beyond that. The other piece of housekeeping is around raising your hand. So when we get to a point where we can do some question asking, you can either raise your hand and we can unmute you, or you can type in the chat some of the questions that you have. So I would like to get us rolling with our actual topic rather than bow ties or me chatting at you. So we have Annie Lakatos again with us from the Inclusion Health Clinic. She has done several other programs before, 2 on hormones and several more on lots of other really fascinating subjects. So I'm thrilled that you're here again tonight, Annie, and I'm looking forward to what you have to share.
Excellent. So thank you, Michael, and thank you for the opportunity to be back in front of everyone. I'm very honored to be here. This has been one of the highlights of my week and of the summer for sure. So tonight's talk is really going to be focusing on non-binary hormone therapy. And I have to just start by saying I really appreciated the term liberated, the person that shared that, because I think when we look at non-binary, we oftentimes come from a social constraint of the binary, so of female, male, and the goal tonight is really to explore what our options are. And I think it's important also to make notice that there's more information out there about trans masculine or trans feminine processes in place. And so these are some of the thoughts that I've come across and want to share tonight. I do also want to just say, as a nurse practitioner, I am not an endocrinologist or a gynecologist. And so I'm going to come at this from my lens of that. So I really welcome questions, and I look forward to that part of our evening tonight. So tonight, what I hope to cover is really how to establish goals of care when you do come in to see a provider about gender affirming care. We are going to go over the current guidelines. If anyone has been a part of my previous sessions on masculizing therapy as well as feminizing therapy, some of this will be somewhat familiar. We're going to talk about how to get started on hormone therapy, what to expect, the effects and risks that you can anticipate, as well as additional considerations. Coming from primary care, I always bring up the health maintenance and the healthcare gaps because that is a particular interest of mine for sure. So I want to start by really opening up the table of saying, you know, in order to provide high quality care, one of the most important things that you can do with your provider is have a conversation about what your goals are. And again, focusing on the binary, which is what our medicine and healthcare system really tends to focus on, can be challenging for people who identify as non-binary. And like Michael said earlier, I'm just going to use that term to encompass genderqueer, non-conforming, and the other terms that are available to use. But really what I want everyone to think about is what helps to affirm and align your gender identity with your gender expression. What can we do in terms of providing appropriate terms, or which includes pronouns, and how do you enable the healthcare clinic that you work with to affirm your identity in that regard? And then I really want you to consider the discussion that you have about prevention and wellness, because one opportunity that we have as healthcare providers is to talk about what we lovingly call an organ inventory, and that really helps to remove an organ from a gender bucket. So having that conversation with your provider is very important as well. And we're going to review that in the health maintenance piece of this talk tonight. And all of this conversation really should serve to empower you to get the right information for your care and for your life. So having the conversation with your providers or provider about what your goals are, and perhaps maybe some of physical changes that you want to see. And actually, prior to tonight, I received some feedback, which I thought was really, really helpful about, again, the social construct that is gender. So we have different cultures in the world, including Samoa and India, that recognize the third gender, and it's just part of their cultural matrix. That's just, it's part of their pattern of life. And I think, and I've had this conversation with people in the inclusion clinic as well, that that's not so readily found in the American culture. So a lot of the conversations that providers have are very, very much based on that binary. So it's very much about the masculizing piece or the feminizing piece. So this is where that conversation is really important to help explore that further. One of the ways that we can do that is to start by obtaining some information about sexual orientation and gender identity. So two very different things, but it allows the process to begin regarding your health risks, your health benefits. What can we do as healthcare providers to empower you? It also gives us the opportunity to say, what are the terms that you prefer to use? And that might be in regards to your gender identity, but also that opens up the door to talk about the terms that you might want to use for body parts, and anything that we can obtain or talk about that will empower that conversation more. And then the expression of your gender. Where are you at today? What is it that you're looking for in a year or in 5 years? So one thing that we might talk about is hair growth, or periods, menses, bleeding, that sort of thing. And we're going to bring that up in just a moment. But it's helpful to know if there is a particular piece of your expression that you want to address. And certainly we can talk about whether or not that would make sense to do through hormone therapy or other means. I want to also say hormone replacement therapy is an option. It's not the only option in terms of affirming expression and gender. And so it's an option that some people want to take on and want to explore and want to pursue, and that's great. But your providers are also, or should be, equipped with information about other avenues to go down. And we're going to talk about that in just a moment. And again, does masculizing or feminizing therapy more align your goals with you know, how you want to express your gender? And that will help enable that conversation to go forward, and so your healthcare provider can support those goals. And then finally, is there any other information that would be helpful for your provider to know about? So here's an example. I just actually saw a patient within the last few weeks who identified as non-binary and found hair to be particularly distressing and dysphoric for them. And that was really helpful for me to know, because that was a focal point of how we wanted to go ahead and address that plan of care. And it did not include hormone replacement therapy. So it didn't include HRT, but what could I do, or how could I support that person in recommending laser hair removal or whatnot? So that was just a recent example. So aligning your identity with your expression, we've got options. So HRT is clearly one of them. I had mentioned the hair removal. There are options. I know in our inclusion health clinic, we do refer people to have this done. There are also many options in the community to help pursue that. When we talk about electrolysis and laser hair removal, very similar thing. So it's the same thing. It's a matter of making sure that you're prepared for several sessions to have that done. And it may not fully remove the hair that you're looking to have removed, but it can certainly address and diminish that hair. The menses suppression is a big one as well. And what we tend to do is we focus on options that don't collide, I think, with the plan of care. So for example, if a person is identifying more on the masculine continuum, I'm not going to recommend methods that may contain estrogen. So that would essentially work against what our plan of care is. But that's a really important piece to know, and to also express to your provider, you know, this is an issue for me, or this is something that I want to address sooner rather than later. What are my options today? What are my options in a couple of years, or more long-term? We also have options to refer people for voice lessons. So we work with speech therapists to help with the delivery of our words and how we construct our voice, essentially. And that can be used alongside HRT or alone as well. So that's another option. And then we have gender affirming surgeries, and that's its own talk in itself, but it's also another method that people use to help affirm their gender. So this might look a little familiar to people. Again, I want to just express that not all sources on the internet are created equal. And so one thing that I like to do with my patients is literally go onto the internet and show them a couple of these websites. And so recognizing that Fenway Health, Callan Lord, and the Endocrine Society are some of the leaders in our nation that have provided some guidelines to us. The University of California, San Francisco also has quite a robust resource for both providers as well as patients. And then the WPATH, or World Professional Association of Transgender Health, they have standards of care. And that document, as I've shared in the past, but as some might know, is rather old or aged. It's from 2012. So it is looking, we're hoping that that'll be updated soon. But WPATH is really beneficial in that it does provide some very succinct charts in terms of looking at what our options are to help support non-binary gender expression. So when I looked at the document, it's about 120 pages long. When I looked at it, and because I wanted to know what they specifically said about how to support people who identify as non-binary. They simply said, you just support this outside of the binary. And then we look at individual care plans and how does that identity link in with the expression. So we can do that. As I've mentioned, where do you see yourself on that, the continuum of expression? Where do you see yourself today? Where do you want to see yourself? And that might change over time as well. And that's an important component. Something might be true today and it might change. And that's where we as healthcare providers need to be somewhat nimble in our information and being able to support your journey as well. There's also an important component about what you anticipate you may see if you do pursue hormones, what you anticipate you will see today or in the first 1 to 3 months versus what may occur over many months or years even. And so WPATH provides that information quite nicely, and we're going to go over that in short order here. Just changing gears a little bit, the University of California, San Francisco, and I've got the website up there. They have this very robust document to help support providers and patients in getting some great information. And so our options at this point for feminizing therapy, or for folks that identify more on the feminine continuum, we offer oral estrogen patches, injections. We can offer androgen blockers, and that's yay or nay on that, depending on, again, what your plan is or what your goals of care are. And then I will say that progesterone is oftentimes brought up. It might not be immediately offered during your first visit, but please know that that's something that if you are interested in or you want to know more, please bring that up with your provider, and we can review kind of the nuances of that at the end of this talk as well. In terms of masculinizing therapy or helping to affirm a person who identifies more on a masculine continuum, we again have gel, patches, and injections. And then the question comes up, what delivery system or what delivery form would be best? And I would really encourage everyone who is interested in pursuing hormone therapy to have this conversation with your healthcare provider who is going to support you on this journey. There's something to be said for a medication that you can administer yourself on a daily basis. So you can use it every day. You can use it every other day. You can really mitigate, the frequency of that. One piece to note that with injections, injections are prescribed either once weekly or once every other week. So once you give yourself that injection, there's no reversal agent. So your body will respond in the presence of that hormone. So it really gets down to what you feel most comfortable using, what makes best sense for your life, but also what really aligns with your goal or your plan of care regarding your gender expression. So how do we get started? The most important thing is to find a healthcare clinic that provides LGBTQ quality care. And that might go along with finding a clinician that you've either heard about or that you've been referred to, or you have the opportunity to review online. So there are many institutions, at least in the Southeast Wisconsin area, that has find a doctor options. That's one way to find a provider. I would say word of mouth is also a very strong way to find clinicians that friends or family members have felt comfortable with as well. I also want to just say that when you come to your appointment, I want you to come knowing that we want you to have a really good experience. So it's really important, if you don't, that we hear that, but also just setting out to that appointment, I want you to know that we work really hard to make sure that every person has a positive experience, but feels affirmed in every step of that journey. I want to also say, I joke with my patients that I ask them 40,000 questions. And I think by the end of the time that I have with them, it probably feels that way. But we do ask a lot of questions because, especially as you're getting to know your provider, they want to know, I want to know how I can best help. So there's going to be a lot of questions about a variety of topics. including gender identity and gender expression. And then be ready to ask questions. I think that's also really important. And we need to carve out time, we need to carve out some time to make sure that we allow space for you to ask questions and to voice your concerns or questions, or I've heard of this. What do you think about this progesterone, or whatever the topic may be? And so that's really the construct, I would say, of those initial visits, but every subsequent visit thereafter. So the primary goal of all those questions that I love to ask, is to help establish those goals of care. And we want to be able to walk you through that process. There are certain things that we ask because we want to be able to give the right information to you, but also that we want to provide you with the options that are available. And I've said this, but I think it's important to really have you don't have to be ready to answer this, I would say, because there's no wrong answers, but don't be surprised if you are asked, where do you see yourself in a year, or where do you want to see yourself in 5 years, so that I can help you get there, or I can give you the right information or the right support. The other thing is, what is the most important thing for you? So I had mentioned my patient earlier who had said to me that hair was a trigger for them. And so that was really helpful, because I saw that as the topic that really bubbled up to the surface that we needed to address more immediately than anything else that we discussed that day. But equally so, what is most worrisome for you? So for anyone who is considering hormone therapy, what about, the effects of those hormones that you don't want to have? So just going along the hair piece, if someone starts testosterone, how likely is it that they would lose hair, or and how much of a concern is that for them? So have that conversation with your healthcare provider so that they can help navigate those questions. And when you start HRT, if that is something that you want to pursue, it's very exciting, because you will start seeing physical changes in those first 1 to 3 to 6 months, depending on what those changes are. And that can be very exciting and very affirming. Alongside those physical changes, you are likely to have emotional changes as well. So, and that goes along with testosterone, it goes along with estrogen for sure. And so those can be very affirming as well. And people have told me in the past that they feel like themselves. They finally feel like themselves, which is it's great to hear, but that's exactly why we have these conversations, so that we can support that process. And then I always like to try to be as transparent with my patients as possible, so that they know what to expect. So when is our next meeting? How often do you want to be seen? For a person who's looking to start hormone replacement therapy, and they don't want to fully present as, for example, male or female, then would it be appropriate to see each other every 3 months or 6 months, or depending on what the plan is, would it make sense to be seen less or more often? And have that conversation with your provider. That will help them know how to navigate any questions that might crop up, but also you then know that you've got an appointment in place to discuss some of the changes that you may or may not be experiencing. So these are the effects that we anticipate from hormone replacement therapy. Many of you may be very familiar with these charts. This is something that I've gone through in the last 2 talks that I had, but I think it's worth reviewing. So this is from WPATH, and this really succinctly illustrates the effects that we anticipate and the timeline. And I like the timeline because it helps us then gauge, do we make any medication dosing changes, or do we just let it coast for a while? We can always readdress and say, actually, I don't want to be on this hormone, or maybe I do want to increase it a little bit more. But you can see the list on the left side of your screen, including changes with your skin and acne, the facial and body hair growth, for sure, something, scalp hair loss, increased muscle mass, strength, that body fat redistribution occurs as well. Something that tends to be very much a point of conversation that I've had with patients is that cessation of menses. So when is that going to occur? I would caution people that tends to stop after about 6 months of testosterone therapy. And that might be a little bit more difficult to achieve if you're on the gel. So just to put that out there, it doesn't not happen, but you may have a little bit more breakthrough bleeding potential on the gel. You can see bottom growth, vaginal atrophy, and then that deepened voice as well. So, and maybe a person is just looking for that deepened voice, and how do we help support that, as opposed to, you know, attributing all of this to a masculine presentation. These charts really help support that conversation to say, what is it that you are hoping for, or how do you see yourself, so that we can explore that further. And then these are the, again, the effects of feminizing hormones. And you'll see that body fat redistribution is there. It's the decreased muscle mass and strength, and the softening of skin, the less oiliness. Sexual side effects are frequently reported with estrogen therapy, so that's an important piece as well. Sexual activity and sexual health is very important, and if that's something that is a very prominent piece to your identity or to your life or to your lifestyle or whatnot, I would say have that conversation, because this medication can definitely affect performance, can affect spontaneous erections, that sort of thing. The other piece in this is that anytime that we do prescribe either masculizing therapy or estrogen, feminizing therapy, that can affect fertility. And so have that conversation with your provider about those effects and what your plan of fertility goals would be as well before you start HRT. And then these are the risks that, just as healthcare providers, we want to go over so that you know the full story, I would say, or the full scoop of, you know, when you start hormone therapy, what do you anticipate? So far and away, the major concern for feminizing therapy are blood clots. So that's something to navigate with your provider. And then you can see the list of the other pieces. People tolerate these medications very well, and they're safe. And so I want to just reiterate that. And on the masculizing hormone list, polycythemia is just increased blood cells, so red blood cells. People can become readily polycythemic if they're dehydrated, but this is a finding that we see with testosterone that would be more persistent. So it doesn't happen with everyone. Again, these are medications that are safe and affirming and really important to help address gender dysphoria or to meet those goals of care in terms of gender expression. So these are the additional considerations, just because I can't help myself, because this is primary, my lens is always primary care. But when it comes to smoking definitely increases risks of cancers. It also reduces wound healing. So anyone who's looking at gender affirming surgeries, either, you know, in the short term or in the long term, this is something that your surgeon is going to ask you to stop if you do smoke. Definitely talk to your healthcare provider if you're interested in quitting, because we have lots of tools that we can offer. Smoking is something that some people just say that they enjoy, and I think that's fair enough. And I want to make sure that people have those conversations to really help identify if smoking is an enjoyable piece of life, then how can we help navigate away from that or to provide an alternative? So, and then the next piece is exercise. Definitely with coronavirus, we've all struggled, I would say, in general, in terms of creating our routines and making sure that we're taking care of the physicality of our needs. But I want to encourage people to use the outdoors as much as they're able to exercise, and walking counts. Walking is a great exercise, but exercise is going to help build your muscles and strengthen yourself, and it will also tone your muscles and really provide the support that your body needs while you're either going on the HRT journey or just for gender expression purposes. Exercise helps your heart muscle, it helps cholesterol, it helps your mental acuity, it improves sleep, it improves mood. There's a whole pile of reasons that exercise is important. stress mitigation or reducing your stress can't be overlooked whatsoever. So stress does funny things to us. It leads to poor memory, and it leads to poor sleep, and poor sleep leads to more stress and whatnot. And so I want to encourage people to take a look at what makes most sense for them to reduce that stress. And if there is something, or talk to your healthcare providers. We tend to have lots of options. We have lots of recommendations. They may not all work for your life, but definitely have that conversation so that we can help address that. And then preventative health, one of my most favorite things to talk about. Cancer screenings are really important for any person who identifies as non-binary. And I would say this, is that our healthcare tools that we have, namely our electronic medical record, can be a bit challenging to navigate when a person identifies as non-binary. And I can get into this ad nauseum, but it's all about the fact that our medical world loves to have the binary all set, and so this is something that I know I include in my appointments, and other people include in their healthcare appointments as well, is to say, if you have that cervix, we need to attend to that cervix at some point. That's a reasonable time or place. Likewise, if you have a prostate, we do need to attend to that prostate. And when you have hormone replacement therapy on board, the prostate, for example, does actually respond a little bit to that. So it's the guidelines for prostate cancer screening is kind of caveated once a person is on HRT. Breast cancer, lung cancer, those are all really important pieces also to talk with your healthcare provider. And since we are still in the pandemic, but we're in the flu season, we are recommending everyone to get a flu vaccination. It's important to say that you cannot get the flu from the vaccination. It is a dead virus there. You can certainly have an immune response that sometimes people can feel like they've had the flu. But the flu vaccine, we are all really wanting to promote that for people. So if you can get it at your pharmacies, you can get it at your healthcare providers' offices. They're all over the place. The human papillomavirus HPV vaccine is also something to consider. It was approved for people up to 26 years of age. It is now approved up to 43 years of age. And that's a really important option for us. Really, it's a vaccination that we have to reduce cancer. So it's really an important conversation to have with your providers. Anyone above the age of 15, you can anticipate 3 injections, just to let everyone know that. And then any other vaccinations out there. So hepatitis B for sure, hepatitis A, those are all vaccines that are available and help promote health. So hepatitis can affect your liver, and that can, in some cases, lead to liver failure. So these are vaccines that can stop that process from occurring. And then sexual well-being. I had mentioned when we were looking at the hormone replacement therapy piece, when a person starts on hormones, that can affect their ability to sexually interact with partners, and just to be aware that that is, in fact, something that you can and should talk to your healthcare providers about. Alongside that, having a conversation about contraception or conception is really equally important as well. So if you are looking to have biological children, in the short term or the long term, what does that mean when you incorporate hormone replacement therapy into your healthcare? Likewise is contraception. So we have methods that can stop bleeding, which is really valuable. And what are those options, and what makes most sense for you today? And you can change your mind. That's an important piece to remember. And then STD testing and treatment, always an important thing to keep in mind. There are options out there in many healthcare clinics to access those options. And then I would be remiss not to bring up PrEP, which is one of my most favorite things truly to talk to people about in my clinic appointments. But PrEP being a medication that reduces the acquisition of HIV through a pill that you take every day. So if that's something that you might be at what we would consider moderate to high risk of acquiring HIV, have a conversation with your provider about whether or not PrEP makes sense for you. So that's about it for me in terms of my material tonight. I am going to stop sharing my screen, and if we have the opportunity to do questions, that would be great.
Cool. Thank you. That was really fun. Again, we do have some questions that have come in already. So why don't we start with some of those, and as folks get other ideas, feel free to add them to the chat. So this first one is kind of a statement and kind of a question. So the person says, my non-binary teen is intersex and does not have sufficient hormone production for bone growth or bone strength and so on. My child needs hormones to grow, but doesn't want typical male or female presentation. Our endocrinologist of 10 years is an intersex specialist, but stumped on non-binary and unclear estrogen versus testosterone. My child chose testosterone, but hated the changes such as hair. And with a provider's agreement, we stopped. So thoughts on that?
Yeah, and I actually, one of the pieces there is the bone health. And I think that's a really important piece to keep considering. So there is something to be said for weight-bearing exercise, appropriate amounts of vitamin D and calcium. The fact that you're connected to an endocrinologist is of utmost importance. And that's where this gets a little bit difficult, and why the exciting thing is that we are seeing more research that's focusing on how to help support folks that are in that situation. And so to keep having those conversations with your endocrinologist, but keeping in mind that bone health is really important, especially as a teen. You want to make sure that that is getting a good foundation at this point.
Great. Another comment more than question is, it looks like Ray from the Inclusion Clinic has made a comment about being the prep navigator at the Inclusion Clinic. So, I think it's really important for folks that are in the Milwaukee area to know that people at the Inclusion Health Clinic are participating and are here and care and are with it. So that's just a kind of a plug for, yay, good stuff.
Yeah.
So someone is asking, and I think this was related to when you were talking about HPV. So the question is, so can you get it if you're older? So I'm not sure if it's about, can you get the series of shots or can you get HPV if you're older?
I love talking about this. So it's currently FDA approved for people up to 43. I would say that the number one thing I would recommend is making sure that your insurance covers it. If they do not, just recognizing that there might be a cost involved with that. Alternatively, health departments might be an option, or other places. So there should be an access point somewhere. HPV is an exceedingly common virus. 80% of sexually active people acquire it at one point in their life or another. And you have skin-to-skin contact, you can get HPV. The HPV vaccine actually covers 9 different strains, including strains 16 and 11, that help support not getting warts. So 6 and 11 are the ones that typically are associated to warts. Some of the other ones, including 16 and 18, can get into your DNA, your cell DNA, and change that cell DNA, which can lead to pre-cancer and then potentially cancer if left unmitigated. So HPV is a really good idea. And I just saw someone, it's a part of my usual conversation about HPV. That first injection starts, that day that you get, then you follow up in 1 to 2 months, and then you get your third 6 months thereafter. So, and typically you don't need a provider to have those appointments. So it should be a little bit more flexible in terms of getting in to get those completed.
Great. So this next question is something that I think a lot of people have questions about. So the question here is, if masculinizing, would you need to keep taking testosterone, or do you take it until you see the changes and then you stop? So Can I add to that a little bit too? Because I think there's some other questions that have come in about, can you take something for a little while and then stop? Are there additional health risks or benefits if you start and then stop? So that whole realm.
Yeah. So let's start with masculinizing therapy. And I've had a patient that has started their testosterone got into, a range that was optimal, and they were seeing changes. They decided to stop because they didn't want the progression to continue. So, and that was completely appropriate. When it comes to estrogen or feminizing therapy, there is a little bit more concern if we start and stop estrogen because of the blood clot risk. So have that conversation with your provider if that's in fact the case. Or is there a method that makes better sense to reduce that theoretical risk of blood clots, which would be the patch. So, or a sublingual tablet of estrogen. Those help us reduce those risks. At the end of the day, the important piece is affirming your gender identity. And what does that journey look like? It looks different for many, many people. So again, it's that nimbleness and that ability to respond appropriately to each patient individually, while still kind of knowing what not kind of, but knowing what those effects might be. So, so I hope that answered that question.
Excellent. Next question is, I grew up with gynecomastia and have often wondered if I may have an endocrine or genetic issue with my sex.
Yeah, that's a great question. So definitely I would bring that up. If you have a primary care provider, they can refer you to an endocrinologist. That would be most appropriately housed in our endocrinology clinic, because they're really the specialists on hormones. They help us navigate those hormone fluctuations, or, why is it that you have this finding, this physical finding? Is there something that we can do about it if you want to have something done about it? So the other piece is that it might help you explore other health potential, like other health concerns that you should be aware of as well.
Great. So this is an interesting, all the questions are interesting, but so the next question is, I want to look more androgynous and less feminine, but I'm afraid of people's reactions, especially in this political climate, since right now I can pass as a woman. Any comments on that? It's hard.
Yeah. So first of all, that breaks my heart, because, but I also want to just affirm that, yes, that is unfortunately what we find. I actually had a patient who came to see me for the first time because they wanted to detransition, and none of my colleagues had heard about this. And it wasn't that they didn't identify as their gender, it was that the societal pressure had just gotten too much. Now, good news, they sought the right care and went through a process, and they're doing great. And but that really helped open my eyes to the pressures and the difficulties that people face. I would say getting connected with a group of people like Forge to really help support your journey, but also to say, we need to hear that we are good people. We are all good people. We are valuable people. Our lives are really important. And just because it doesn't fit neatly into a little square box doesn't mean anything. It just means that it doesn't fit into a little square box. So I'm sorry to hear that. And I'm very glad that you're here tonight to hear something different, I hope.
And I'm really grateful that folks are here too, that have some of those struggles with what's going on in our world. And I know that all of us have to weigh safety of many different kinds. So medical safety, emotional safety, physical safety. And sometimes it's really hard to figure out which of those safety pieces or which of those comforts kind of comes out on top. So those are hard things to parse through.
Yes.
The next question is a little bit similar to one before, but do you need hormones? For example, does a non-binary person ever have to choose? Good question. Can I stay on Lupron forever?
Yeah. So do you need hormones? I would say you don't need hormones. What you need is a really good conversation with your provider to say, these are my goals and I've met my goals, or I'm there, or I'm not quite there. So nothing is set in stone, and we have guidelines to guide us. This is not a recipe at all. This is a way that we can help affirm and align our gender and our expression. So I would say have those conversations for sure.
Yeah, definitely. So next question is about baldness running in this person's family. And they say, I'm non-binary, born female. I'm terrified of experiencing hair loss if I use low-dose tea. Is there a way that I can see if I have the genetics that will lead to this hair loss if I use tea?
That's so good. That's such a great question. And that question is not, I've heard the question before. So I want to tell them, yes, that is a very legitimate, but it's a good concern. I would say that this is where the effects of hormones really plays into genetics, and we don't typically have an avenue to, I would say that if you were referred to a geneticist, I'm not sure that there would be a way to say, yes, definitely, you are going to lose hair if you go on to tea. We do have products that we can offer, or we can also just continue to monitor for those changes. I know that in the Inclusion Health Clinic, one of my colleagues had a patient that really struggled with hair loss. And so they changed from injections of testosterone to a patch to see if that could help reduce or mitigate that effect. So, but, and I want to just highlight that that was a conversation that, because the provider knew that that was a really important piece of their care plan. So, good question.
And I think that taps into a little bit of what you were talking about earlier, which is like, what if you want certain effects from hormones, but not others, whether it's hair loss or not being hairy or, menstruation stopping, but not these other things. It's like, we can't always pick and choose like just the things that we want.
Right.
And then, do we add in some of those other things like, a hysterectomy instead of being on hormones if menstruation stopping is really what's important. So
Right. Absolutely.
Those are challenges. Yeah. So there's a comment in the chat, and I think it's more of a comment than anything, which is about insurance coding. So it's really important to know that the little known KX modifier. So I encourage folks to read that comment because I think it's really critical that sometimes our care gets delayed or stopped because of how we code things. Yeah. Question is about, is a referral necessary to get an appointment to discuss hormone therapy at the Inclusion Health Clinic?
So it is. We do offer in-person as well as virtual appointments, and for the most part, so I would say many of us actually provide hormone replacement therapy. So you have an option to see, we have 3 primary care people, we have 2 gynecologists and 1 endocrinologist. So all of us do HRT. So we've got that option. And I would say having an appointment carves out that time that is dedicated to have a meaningful conversation. So life is busy, appointments can be, back to back, and certainly the days can be very, very long. But to really have a conversation with someone, I would say it should be an appointment so that you know that you've got that time. So.
Excellent. The next question is, I've read that testosterone can change or lessen chronic pain, and also that it can affect mental acuity and depression or anxiety and other mental health concerns. Can you speak to all of that?
Yeah, so I'm not sure about the chronic pain piece, but definitely testosterone can be very activating. So if a person has some undiagnosed or poorly controlled depression, anxiety, T can really activate that. And so that can provide a little bit more of activity, sometimes in some circumstances, suicidal ideation. So we have to be very careful in that. And that's part of the conversation that you have with your provider about that. I will say that we use a scoring tool called the PHQ, or Patient Health Questionnaire, to help really to capture depression. In so many cases, my patients have a score that's very, very high. So it goes from 0 to 27. The higher the number, the more severe the depression would be. And I routinely have patients in the 20s, and a lot of that is triggered by gender dysphoria. And so is it something that I am concerned about? Absolutely. Do I treat with antidepressants? Not necessarily. I oftentimes treat with hormone replacement therapy if that's part of their plan. So I won't say this is what you need because this will treat it, but it's definitely a consideration. So for anyone who is considering HRT, low dose, or more on the somewhere on the continuum, I would say make sure that you are having that conversation and that you've got the right supports in place if you have struggled with depression and anxiety for some time.
Excellent. And just to anecdotally add, I think a lot of things we don't have hard science research to, but we have seen so many folks who've started testosterone and have had more energy. So I know that's not about chronic pain, but we've definitely seen that folks that have chronic pain oftentimes have chronic fatigue. And so a lot of times people that are taking testosterone, it actually kind of gives a little bit of a boost, which, is oftentimes very helpful for folks, but it's not about chronic pain. Next question. I am brand new to this as a parent of a 7-year-old non-binary kid, assigned male at birth, they, them, or she, her. Could you clarify on dosing? If a person doesn't want a dramatically feminine presentation, can they pursue a less strong dose of feminizing hormones, perhaps just to offset genetic predisposition?
Yeah, so as a 7-year-old, we wouldn't necessarily use hormones at this stage. I would say that we would consider blockers, and that's a realm of care that I'm not as familiar with, I would say. So Children's Hospital has a great gender clinic that you can get connected to in that regard. If people are interested in looking at that dosing piece, the University of California, San Francisco, when you look at that website and you'll look at masculizing or feminizing therapy, it gives you a chart. And so there's a low dose initial, and then there's a typical starting dose, and then a maximum. So it gives us, again, the guideline to start prescribing. But again, with a 7-year-old, I would definitely recommend getting connected to the gender clinic at Children's. They have an exceedingly well supported clinic there that can help navigate those questions.
Perfect. Next question. Alcohol runs in the men in my family. Is that something I should be worried about if I start on tea?
No, not necessarily. So alcohol abuse definitely has a genetic component to it, and so recognizing that that is something, I would say, have that conversation with your provider, and they may ask you then more frequently about your alcohol use, or if you're concerned about your alcohol use. When we think about medications, a lot of our medications are processed through the liver, and so as well as the kidney, but we want to make sure that we're not damaging that liver. And in some cases, liver function can be affected by HRT, and that's something that is monitored on a fairly routine basis through labs. So there's something called a comprehensive metabolic panel, or CMP, and that would show liver function, kidney function, as well as electrolytes. So that's something that you can anticipate having done every 2 to 3 months or every year, depending on where you're at in terms of your journey. But if you're concerned at all about that, I would say that there are resources to help support you in that regard.
There were a couple of comments about puberty blockers, and I'm just wondering, I know that kids are not your mainstay of who you see, but could you comment about if puberty blockers permanently affect infertility, or permanently affect fertility, or any other permanent changes?
Yeah, that's a great question. I mean, the point of puberty blockers is really to stop the effects of those hormones from developing those secondary effects. So, the Adam's apple, the lower voice, the hair, the sex organ changes, those sorts of things. And so, truthfully, I don't know what those long-term effects are. They typically stop at 16, though, and that's when I start seeing people for hormone therapy. And so if anyone is interested, again, having that conversation with the Children's Hospital is one place to go, Children's Hospital Gender Clinic, because then they would also establish that pathway of, here you are getting care in our clinic, and then you'll eventually transition to HRT to supplement that as well. So I'm sorry, I don't know more about that.
And those are, yeah, that's not your wheelhouse. You've talked a little bit about this next question, but what are some of the benefits of, or the downsides of microdosing?
Yeah, so I would say that when people are using medications at what we might consider subtherapeutic, like any effects might not be seen or felt, and so that's something just to be aware of. I'd be curious to know a little bit more about the microdosing, though, context as well, because I know about microdosing in other contexts as well. But if we're talking just in terms of HRT and that low dosing, my understanding is that it would provide some of those changes, again, to affirm a person on a continuum of expression. So staying away from the binary poles, essentially, would be the primary motivation, I would say.
Cool. Another question. I know that we're at 3 minutes to the hour, and I asked this the other two times. Annie, are you able to stay a little bit past the hour?
Absolutely.
Okay.
Absolutely.
So we're going to keep going, and I want to recognize that some folks may need to leave at 7 o'clock, but we're recording, so you can come back and watch if you'd like to hear the rest of the great answers. So the next question is, I don't know if this is related, but I'm worried about what will happen with my job if I start to move towards a more masculine presentation. Do you have any suggestions or experience with situations like this? Is there an amount, a low dose, or something that can help with small changes that won't be overly obvious?
Yeah, that's such a great question. And I would say that that is not a unique situation. And there's a couple of things there. I would say starting low dose so that affirmation is occurring. And there are going to be changes that people might not see or not, there aren't overt changes, but that you will experience or you will notice in some cases because, you see your body and other people see your body with clothes on. So there's that piece. I would also encourage people to talk to human resources or their managers or someone that they trust to say, this is a potential for me. And how do I navigate that? I know some of my patients have waited until they've made a job change. Some of my patients are in situations where they have a very public facing job, like a teacher. And that I think is a very complicated situation as well for them. But recognizing that, that I want people to feel that they can reach out to organizations to help navigate some of those legal issues, but also find someone that they can trust in that organization to help understand what their rights are and how that can be done. In some circumstances as well for working, it's never been done before. So that might be an issue that people will face. I know at the medical college, a number of people have transitioned at work and that is a process that happens. And that is end of statement, new paragraph. So, and I hope that at some point that's where we're gonna all get, is that, yes, this is what happens. But yeah, that's a great question.
And like somebody mentioned before, we're living in a world right now that's a little bit toxic and a little hostile. So I think a lot of us are fearful of what might happen, even if it may not happen at our work.
Yes, absolutely.
A couple more questions that have come in. If you get a hysterectomy and do not do hormone replacement therapy, do you still have viable eggs since you still have ovaries? So let's assuming that there's no oophorectomy. Could you use your eggs for IVF with a female partner?
That's a great question. If you have retained ovaries, I would say that would probably be an option for you as well. Before you have that hysterectomy, you would have that conversation about fertility preservation. So would it be more meaningful or a better idea to have egg preservation prior to the surgery versus after? I saw some estimates of price recently, and it looks like, and I don't know the prices for sperm preservation, but for egg preservation, it looks to be about $13,000 and then a yearly cost to maintain those eggs. So it can be very cost prohibitive for people, but it's really worth the conversation as well.
So there's a couple of questions about blockers again, and this is straying a little bit off topic, but I think it's really related because a lot of times when we can, when kids are at that age, we can kind of leave the options open. So this question is, can a child stay on blockers forever? Do they ever have to go through puberty?
Good question. I would say that they don't stay on them forever because there is that time where they will transition to hormone replacement therapy. Do they ever have to go through puberty? HRT in so many ways is its own puberty. And I warn folks about that sometimes, that I'm like, you may have changes in your emotions and your physicality. So, and that can be something, and it's awesome, and it can be scary and awesome all at the same time. And so just to understand that might be an occurrence as well. So the gender specialists that help support kids through that process will definitely are supported not only by medically trained people, but psychiatrists, again, not because there's a pathology there, but to help process the experience and to make sure that everyone feels well supported.
And I'm just scrolling back up. There are a couple more if you're willing and able to stay.
Yeah.
Um, So I think you answered this already, but there was a question about the WPATH and UCSF charts and kind of the presumption of the timeline being with a kind of a normative dose. But I think you just mentioned that there was kind of like a low and the average and a higher dose. Is that correct?
Yes. Yeah.
Okay.
Yeah. And so those are from UCSF and WPATH. Again, like if someone is on a lower dose, for example, testosterone, and they're still having breakthrough bleeding on a monthly, that's not super surprising. And so I would recommend for that person to consider something like a progestin only contraception, like Depo-Provera, an IUD, or Nexplanon, because those are safe, very effective methods, but that would suppress that bleeding very effectively.
That's perfect. And I'm just looking at some of the other questions, and it looks like a lot of them have, you've already answered many of them. Could you talk a little bit about the things like lab tests and providers who are more familiar with binary oriented transitions and are looking at lab tests as kind of the be all and end all? So if somebody is non-binary, if they're using low doses, how are those lab tests and some of those other markers maybe seen by providers?
Sure. So oftentimes we'll get labs that are going to look at liver function, kidney function, electrolytes, complete blood count. So that'll look at red blood cells, white blood cells. And then it will look at testosterone and estrogen levels. So I would say if a person is looking to transition to fully, male facing, I would say, yes, I want that estrogen to be fully suppressed and that T to be at a certain range. When we're looking more at non-binary and a non-conforming presentation, I would say my understanding and my experience has been that we would look at those labs and say, yes, there has been a shift in those hormones. Again, electrolytes and blood counts are all okay, but how is that person feeling? What changes are they seeing? And is that aligned, I think, with the goals of care? So oftentimes, yes, labs will help dictate certain things, but it shouldn't be the full picture. So it should absolutely be, how is that person feeling? What changes are they seeing? And again, is that in line with what they want and want to continue?
Can we do two more questions and then wrap up? So one is about, does T interact with thyroid hormones?
That's a good question. I would say if you are on T and you're also on levothyroxine or Synthroid for thyroid, you want to make sure that your endocrinologist is aware of that, or if it's the same person that's managing both things, that they may require a little bit more frequent monitoring. But in terms of outright changes, I would say not. Make sure that you're taking that levothyroxine in the morning by itself with no other medications and just on an empty stomach. That's going to be your best bet in terms of regulating your levels in terms of your thyroid function. But there might be some more frequent testing, I would imagine, but possibly not.
Cool. The last question that we'll do for tonight is, I saw a symptom for masculinizing therapy that was distressful urinary symptoms. So the question is, to what level? I'm not finding any more in my research.
That's a good question. I've not heard that. And in fact, for the most part, I've not heard that from my patients, and I'm not sure about that. If someone is having that symptom, definitely that's a workup that needs to be explored with your provider. But in terms of just as a result of T, I'm not as familiar with that.
There are always more questions, I think, than we have answers to, and we don't have research, and we see anecdotal things, so it's tough. And I know there's still more questions coming in. I will capture those questions. If folks want to leave your email address, you can send it to me privately. We will try to address those questions by email or some other way. So I wanted to quickly review what's coming up. We have some really cool programming coming up, and in addition to thanking everybody for being here, what's coming up this week is we have Redefining Realness, Janet Mock's book, on Thursday. So Matthew Lewis and Naomi Jones are going to lead that discussion. We have free books that we can send you, so drop us a line and we will be happy to do that. Lori, if Caleb, can you drop the form in the chat box? That would be great. And then on Saturday, I am super excited that we've got Jen Elkhorn, who is a trans elder and who was around when kind of the Harry Benjamin days in Stanford. And so she's going to talk about her journey, and that will be really fascinating and really interesting. So those are the two other things that are coming up this week. We wanted to remind folks too that we have many cloth masks that we can send folks. So feel free to ask for them and we will send you as many as you want or need. And then the last piece of business is that you'll receive an evaluation when we close out tonight. And we always care about your thoughts and your feelings and what you think about our session so that we can make improvements and changes as we move forward. So thank you, Annie, again for being like so generous with your time and so generous with your, like, everything about you is just fantastic. So thank you very much.
It's my pleasure. Thank you very much for tonight. This has been great.
Way cool. And thanks everybody for spending your evening with us. Our interpreters and our captioner, thank you too. We will see you hopefully on Thursday, everybody. Have a good night.